Greetings. Let us talk about the role of injection catheter and submucosal saline injection in GI endoscopy. These are my acknowledgements, and our learning objectives include: number one, we will learn about the purpose of saline and other solutions for submucosal injection and how to do safely saline injection or any of the other solution injections. This is one of the most important things in endoscopy, injection of a solution. When you see a flat polyp and you want to inject saline or any other solution into the submucosa and lift it above the muscle, you need to know how to prepare for that. So you can inject plain saline or one of the solutions that are readily available in the market. Or you could inject saline mixed with a little bit of dye, either methylene blue or indigo carmine. The blue dye stains the submucosa, the connective tissue blue, so that it helps the endoscopist figure out the depth of resection once the cut is made. In addition to methylene blue, some endoscopists may use a little bit of epinephrine, and that causes spasm of the blood vessels and cuts down the risk of bleeding during a polyp resection. Some use viscous solutions like heterstarch, and it all depends upon the endoscopist's preference. So you've learned that there are different solutions, but the commonest solution that is used is saline. And once you got your solution ready in a syringe, typically you use a 10 cc syringe. 10 cc syringe is the best syringe for a good injection. Anything bigger or smaller can cause some problems. Once you have the syringe filled with a particular solution, get into the habit of labeling the syringe with the type of solution in the syringe, the date and time, and also the initial, your initial, who prepared that solution. So you have your syringe solutions ready, and now you go to the cabinet and pull out an injection catheter that comes out in a plastic sheet, and you take out the sheet, and this is how an injection catheter looks. It has an inner plastic tube with a needle at the end, and that inner plastic tube is enclosed in an outer plastic sheet. And the needle is covered and protected by the outer plastic sheet. And there are a couple of, there is a technique to move the inner catheter out of that outer plastic sheet for the injection to happen. So once you have your syringe and you have your injection catheter, I want you to practice the following. You fill your syringe and get rid of the bubbles, and then use that syringe filled with solution to prime the needle. Make sure the needle is filled and you see the saline come out from the other end. Get into the habit of holding the syringe always facing down, because if by accident there are small bubbles in the syringe, they float up and doesn't cause any problem. You also need to check your injection catheter, whether the needle is going in and out before you give it to the endoscopist. And how do you do that? So here, this is how the injection catheter comes out of the sheet. The needle is enclosed in the outer sheet. and you pull on the outer sheath towards the syringe, and the needle gets exposed. That is needle out. Most endoscopists use the term needle in, needle out. And you know what to do for needle in and needle out. And once you check that your needle is working, needle is primed, and make sure that the needle is back in the sheath before you give it to the endoscopist. I would like you to practice the following steps to give a good injection. Learn to tap on the syringe plunger and see how much of fluid squirts out. This is a good experiment for you to do. How much can you inject? The tap should get out less than a few drops of fluid out, but forcefully. And once the endoscopist tells you to inject, get into the habit of saying loudly the amount of fluid injected. 1 cc, 2 cc, 3 cc injected. The reason why it's important is if you're injecting and you don't say loudly how much you injected, and the endoscopist is thinking that you're still injecting and you have already completely emptied 10 cc's of syringe, the endoscopist may have dropped all the 10 cc into the peritoneal cavity because the needle has gone through and through. So the endoscopist would know and make necessary adjustments as you say loudly 1 cc, 2 cc. So if he's not seeing the nice bulge appear, he will pull the needle back and readjust. For that reason, get into the habit of saying loudly the amount of fluid injected. So here is a case. Here we see a polyp, a flat polyp, and we want to inject and lift it above the muscle. So here is a flat polyp, and you've already primed your injection catheter. You have pulled the needle back into the sheath and gave it to your endoscopist. The endoscopist has pushed the catheter through the biopsy channel and is come out into the field. And once it's out in the field, he will ask you and say needle out. That means you pull the sheath back and the needle comes out. And then the endoscopist makes a gentle puncture, gets into the submucosa, and you do tap, and then it gives a nice lift. And once it is done, the endoscopist will pull the needle back from the submucosa into the lumen, and then he will say, we need to get needle out. Let's take the catheter out and get me a snare. In that case, you need to first pull the needle back into the sheath. And this is what you do to get the needle back into the sheath, and then take the injection catheter out of the endoscope channel. So we have learned a lot. I want to summarize some of the do's and don'ts about injection catheter and saline injection. Do prime the needle with fluid. Get rid of all the bubbles in the syringe. Hold the syringe facing down to avoid bubbles escaping out. Check your injection catheter. Make sure the needle is going in and out of the sheath before you give the injection catheter to the endoscopist after pulling the needle back into the sheath, so that it is safe and you do not injure the endoscopist. I want to repeat here, there are certain no's that I do not want you to do. Do not expose the needle before giving it to the doc or to anybody. You will cause injury. And do not expose the needle in the endoscope channel. You will damage the channel. Channel damage is anywhere between few $1,000s in terms of repairs. I hope this video is useful, and I wish you the very best. Thank you.